Well, hello, everyone. I'm Dr. Leslie Kernisan, board-certified geriatrician and the founder of the website betterhealthwhileaging.net. And this is the Better Health While Aging video podcast, where we discuss common health problems that affect people over age 60 and the best ways to prevent and manage those problems. In today's episode, we are going to talk about a topic that is relevant for many older adults, which is bradycardia, which means a slow heart rate, and pacemakers. Now, since it's not uncommon for older adults to develop a slow heart rate or other heart conditions that might require a pacemaker, I think it can be really useful for older adults and their families to understand this better. So I'm really glad to be able to bring back today one of my very favorite cardiology experts who can explain the most important things to know about pacemakers today. My guest is Dr. Cara Pellegrini. She is a cardiologist specialized in electrophysiology and a professor at UCSF, and this is actually a big part of her day job, is treating this type of condition and putting in pacemakers and related devices. So, Dr. Cara, thank you so much for coming back to talk with me about this topic today.
Dr. Leslie, it's my pleasure. I'm excited to have our discussion.
Okay. So why don't we start by first talking a little bit about what is a pacemaker, and then maybe we can talk a little bit about slow heart rates. So let's start with a pacemaker. What is a pacemaker and why do we use them in medicine?
Yeah, good question. So a pacemaker is an electronic device that is able to both sense the heart's intrinsic activity, electrical activity, and then give a stimulus to the heart to create a heartbeat. And we use them generally for people whose heart rates are too slow.
Okay. And I think as you've explained before on the show, the heart, which is a pump, has a special node, right, that generates the electrical impulse. And then it comes down through the top of the heart. And the top two chambers of the heart are the atria. And then it kind of spreads down to the bottom two chambers, the ventricles, which are the bigger pumping chambers. Is that right?
Yeah, that's exactly right. So to make the pump, which is the heart, work more efficiently, there's an electrical system that tries to make sure that all the parts of the heart are working together in a synchronous, efficient manner. And you can think of the sinus node as the conductor of the heart. It sets the beat such that the heartbeat is usually about once a second or 60 beats a minute. And then that signal is transmitted to the middle of the heart where there's a little way station called the AV node that then sends that signal out on high-speed wires to the two main bottom pumping chambers so that those pumping chambers, the right and left ventricle, are able to contract and everything is beating in a nice synchronized way, starting with the atrium, leading to the ventricle. And that is all thanks to the electrical system of the heart, which kicks off with the sinus node.
Okay. Now, you came previously to talk to us about atrial fibrillation, a really common condition in older adults. And often in that condition, the heart beats too quickly. And I know that often in your work, you're helping people who have hearts that are beating too quickly for various reasons. But today we're talking about bradycardia, when the heart goes too slowly, because that's when often we might use a pacemaker to help it go a little faster. So can you talk a little bit more about this condition, bradycardia, slow heart rate?
Yeah, definitely. So our empiric definition of bradycardia just means that the heart rate is slower than 60 beats a minute. For many people, that is normal and fine, including young athletic people and some older people too. And really, when we worry about pathologic bradycardia or when we start to think about pacemaker is when people have low heart rates that are associated with symptoms. And I'm imagining we're going to speak in a few minutes about what some of those symptoms are. But really, it's the combination of having low heart rates that are too low for someone's needs and therefore having associated symptoms.
Okay. Yeah, I totally want to talk about the signs and symptoms, but really quickly, when you're seeing a pathological heart rate, like one that you would find worrisome as a health provider or that's likely to be causing symptoms, like what kind of heart rate are we talking more or less?
Yeah. So certainly we would worry if it was a very low heart rate in the 20s or perhaps in the 30s. Sometimes people have resting heart rates in the 40s and 50s, and then when they exert themselves, their heart rates go appropriately up over 100 beats a minute, and that can be fine in an young athletic individual. In an older person whose heart rate is in the 40s at rest, I might start to wonder if that's because of this pathologic bradycardia. Some other things to consider, for some people, the heart rate at rest is still okay, maybe in the 50s or 60s, and they feel okay. But then when they exert themselves, their heart rate is unable to increase sufficiently for exercise. So maybe they cap out at 80 beats a minute, which would be fine for rest, but is insufficient for a certain level of physical activity. We have a fancy
Hmm.
term for that. That's called chronotropic incompetence. And that can be actually one of the very earliest signs of a dysfunction of the sinus node.
Right. Because your heart is normally designed to kind of sense what's going on in the body. Because if you start to exert yourself, you need more blood flow, and your heart should be able to pick up the pace, literally.
Yeah.
Right.
Z- Well,
And so if it can't pick up enough to meet your body's needs, it's sort of underperforming, and people can get symptoms from that. All right. Well, in a moment, I want to have you explain to us a little bit more about what causes that, especially as people get older. But maybe we can just quickly review what are symptoms, signs, and symptoms that happen when somebody is having a low heart rate, bradycardia.
Yeah. So there can be a range of symptoms, but things like dizziness, shortness of breath, fatigue, particularly feeling short winded with exertion. For some people, it can include things like a little mental clouding or confusion, even. And then with regard to signs or things your doctor might notice, we talked a little bit about the number, your heart rate number, if that's really low at rest. We talked a little bit about that the heart rate might be okay at rest, but might be insufficient with exertion. And then the third thing I'll mention is sometimes there can be pauses where the heart rate can be normal some of the time, but then sometime have long periods of no heart rate. And so those would all be things that the doctor or your health provider might notice.
Yeah. And I just want to ask about one other sign or symptom that seems to come up, at least for us in geriatrics, which would be, what they call in medical terms syncope,
Mm.
when people pass out or maybe almost pass out. Do you also find that that's a sign that sometimes is associated with low heart rate?
Yes, it can be. So it can progress beyond dizziness to this kind of pre-syncope or syncope. And obviously, there's a range of reasons why that can happen, but that can be a sign of an extreme bradycardia. Absolutely.
Yeah. And actually, some of those signs you mentioned, just shortness of breath, especially with exerting yourself, those are signs that can be related to other kinds of heart problems as well,
Good
such
point.
as heart failure, which you have also, explained to us about. And I'm remembering that it's that. So these are, I think, symptoms that can be fairly common, and they can often be due to a variety of heart problems, or could even be something else.
Well said.
Right.
It's true. And so it's the detective work of putting together the constellation of things that a person is feeling with what things we're able to observe and perhaps do some additional testing to help tease things out. And that's, yeah, that's the fun of the job.
Yeah. So tell us a little bit more about how you actually end up diagnosing bradycardia, or what is like sort of like testing that we would do as health providers to, again, suss this out if somebody's feeling weak or tired or dizzy or short of breath when they walk around.
Yeah. So you bring up a great point, which is the context of someone's symptoms can sometimes help us think about which test to do. So if someone's feeling just fatigued all the time, getting a baseline heart rate might be sufficient. And so that's as simple as putting a little pulse oximeter, a little monitor on someone's finger when you first go to the doctor's office and getting some vitals. And if your doctor notices that that number has gotten a lot lower recently and is kind of staying low, that's already kind of raising this diagnosis as a possibility. Sometimes we need a little bit more time of observation to kind of figure out what's happening at the time that these symptoms are happening. So if they're more exertional symptoms, finding out what's happening to the heart rate at the time of exertion can be really helpful. And we have kind of two ways of doing that. One is to have you do exertion in the office or hospital in the form of a stress test. So having someone walk on a treadmill and monitoring what's happening to the heart rate with that level of demand can be useful. But sometimes even more helpful can be to get a longer snapshot, to have someone wear some sort of patch or type of monitor that we can look at what's happening to the heart rate over a week, 2 weeks, a month, and then correlate what we're seeing with times the person is symptomatic. And that can be really helpful. And lastly, I'll just mention doing a 12-lead ECG in the office gives us a little snapshot of about 6 seconds, 10 seconds, sorry. And so that's when the doctor puts a bunch of sticky little stickers on your chest, and usually one on each arm and leg, and looks at the electrical activity of the heart for that 10-second period. And that can be informative too.
Okay. So it sounds like when it comes to a slow heart rate, the person might be having symptoms, which, as we said, might be, fatigue, dizziness, less ability to exert yourself, maybe almost passing out or passing out. We definitely think about it when a very old person falls in geriatrics. Or possibly they just notice that the heartbeat is kind of slower than we would expect, maybe under 50 when they're in the office. Or this might actually be the kind of thing that people's devices now pick up, Apple Watches.
Good point.
And the such. And so after that, it could be confirmed in the medical office, maybe do an ECG. And then if more information is needed, maybe doing one of these longer term studies of what's happening with the heart rate through the patch, or having people come in for a stress test. And that's how you would confirm the bradycardia.
Yes.
Right. And then I know that for you, especially looking at the pattern of the electrical signal, you also see kind of in more detail in which part of the heart the issue might be, right?
Yeah, exactly. So there's two main categories where the problem could be. One, as we were talking about, is the sinus node. So the sinus node, if you remember, that pacemaker or conductor of the heart, can sometimes go too slow. And that is what we call sinus node dysfunction. That typically is something that progresses slowly over time and can lead to many of the symptoms we were talking about, such as decreased energy, mental clouding, maybe some dizziness, more often just kind of a fatigue or a loss of exertional capacity. The other reason that slow heart rate can happen, or that we could think about a pacemaker, is something called AV block. An AV block is when the signal from the upper chamber, the sinus node, is doing just fine. The sinus is catching its beat every once a second or so, but the signal is not getting from there to the bottom chambers for them to contract. So the pulse is still going to be low, but it's not because the pacemaker of the heart is not doing its job. It's because that signal is getting blocked along the route to get there. And this actually can be a more acute and life-threatening presentation, because it can happen all of a sudden and therefore can lead to things like syncope, passing out, or a fall, or something more concerning.
Okay. All right. So tell us a little bit more about, so what are these most common causes of developing this bradycardia, especially when it comes to older adults, people in their 60s and older?
Yeah. So the most common etiology is just related to the aging process. As we age, a certain amount of scar tissue called fibrin gets deposited within the heart and other parts of the body. And as that happens over time, it can disturb the electrical communications of the heart. And this can be accelerated by things like high blood pressure or other cardiovascular risk factors. And in fact, controlling blood pressure well is one thing that can help slow that process. There are other potential etiologies for having slow heart rate or bradycardia. Sometimes medications that we give for some other condition can lower the heart rate. And if possible, to stop that medicine, that may be sufficient to reverse the problem. Additionally, sometimes procedures that are done on the heart, such as valve surgeries or procedures, can create a certain amount of inflammation that can block that electrical signal. Very often that can be reversible with a period of time and healing. And so Sometimes we wait it out and things recover. Additionally, other sorts of infections or systemic disease processes of inflammation can create heart block or sinus node dysfunction. But far and away, the most common etiology is just kind of the normal aging process.
Okay. So if I understand right, the most common cause is sinus node dysfunction, right? Where the sinus node just gets slower.
Mhm.
And that has also historically been called sick sinus syndrome, right?
Mm-hmm.
But now we call it sinus node dysfunction. And the cause of sinus node dysfunction is most commonly just aging and the electrical system and that little node slowing down.
That's right. So that deposition of scar tissue can happen within the node, or can happen at the connection of the node to the rest of the tissue and just make that signal not get out as well.
Okay. And so as people get older, how common is sinus node dysfunction?
Yeah, that's a great question. It's pretty common. It really is a disease process of the elderly for the most part. Approximately 200,000 people get pacemakers in the United States every year, and about 70 to 80% of those people are over the age of 65. So it's reasonably common.
Mm-hmm. And again, becomes more common, I guess, as people get older because the older you get, the more likely you are to have age-related changes to the heart that can interfere with
Exactly.
its normal function.
Yep.
Okay.
Yep. So if someone in their
Um,
80s is at more risk than someone at 67, for sure.
yeah. So let's now talk about how do we treat bradycardia, especially sinus node dysfunction in older adults.
Yeah. So there is no medication that speeds up the heart rate. So our first step is to make the diagnosis. And then next, we look to see, are there any reversible causes? Is there a medication that can be stopped? Is there an electrolyte that's out of balance that we can correct? Is the thyroid function normal? Has this person been exposed to Lyme disease? And so we'll hunt a little bit to see if there might be something that is reversible. In the absence of any obvious reversible etiology, pacemaker is really the mainstay of our therapy. As I said, there's generally not a long-term by mouth medicine that we can give to resolve this problem.
Okay. And just to, you mentioned that medications sometimes slow the heart rate down. Can you just speak to because some of them are actually fairly commonly used medications that slow down the heart rate.
hmm
What are some of the ones that you especially see slowing down heart rates?
Yeah. So the most common are things that are called beta blockers or calcium channel blockers. Those are medicines that can be given for other heart conditions, such as preventing heart attack or treating heart failure. Sometimes these medicines are given to control blood pressure. And in that case, we can use a different sort of blood pressure medicine that doesn't have heart rate lowering effects as well. There are other medications too, such as digoxin or some of the medicines we use to control fast heart rates. So, antiarrhythmic medicines like amiodarone and others can also slow heart rate down. And then I'll just mention that beta blockers can also be given in the eye as eye drops for people with glaucoma. And sometimes you can have enough systemic absorption of that medicine that it can also slow the heart rate down. So it's important to think about all medicines, not just the ones that are being taken by mouth.
Okay. And so, as you said, after you look for reversible causes, you might try to adjust medications, see if you can get a person's heart beating fast enough for their needs. At what point do you decide to consider a pacemaker?
Yeah. So definitely it's something for sinus node dysfunction that is not considered an emergency and really is a discussion between the person I'm caring for and myself, where we spend some time trying to suss out how likely we think a pacemaker would make this person feel better. So as you mentioned, a lot of these symptoms that people might feel can be due to a host of different reasons. And so really trying to get a sense of how much the bradycardia is really what's driving someone's symptoms. And if we feel reasonably confident that that's the case, then I would offer and suggest pacemaker, and we would talk about it. I will say that it's not uncommon for someone to not be eager about the idea of having an implantable device, ultimately get the pacemaker, and then just be over the moon and so thankful that, that they eventually made that step and kind of kicking themselves that it took so long. So that is something that I see. I'll just throw out there again that there is this other etiology, not to be confused, this AV block situation. And in that situation, again, it can be more of a matter of safety and life and death. And in that scenario, it's a more straightforward and quick discussion and decision process usually.
Okay. And I want you to tell us a little bit more about how pacemakers work. And maybe we can also start. I know there are actually several different kinds of devices that you put into people to help them. Can you just quickly describe how a pacemaker works, but also what are the related devices that I think people sometimes lump in with pacemakers? Can you just speak to that for a little bit?
Yeah, absolutely. So a pacemaker really has three main components. The first is a battery, and the battery is what allows the pacemaker to continue to work over time. The second is some sort of connection to the heart tissue itself. And that can be in the form of a wire that goes through the blood vessels and ultimately touches down on the heart's surface, or little electrode probes on the tip of a little capsule type pacemaker. And we'll talk about that in a second. And then the third component is the computer part of the pacemaker. And that's the part that kind of sets a time and says, okay, a second's passed, there's been no heartbeat, better fire and create that stimulus to create the pacing of the heart. So those are kind of the three components. Traditionally, pacemakers have been what are called transvenous pacemakers, where there will be a little can or the device with the battery and the computer up near the shoulder, very commonly on the left side, but for some left-handed people, we put it on the right side. So that sits up there and then has the leads that go down into the heart and into the blood vessels. In the last few years, another option has come forward, which is called a leadless pacemaker. And the leadless pacemaker that you might be able to see on your screen here is a little metal capsule that is a self-contained device. The battery, the computer is all contained in there. And at one end is a little, the non kind of button end. At that end that either has a screw or the little kind of fish hooks, there's a little electrode right in the center that touches the heart tissue and that allows the sensing of the device of the person's intrinsic electrical activity to occur, as well as the output from the device to the heart of that electrical signal to stimulate a beat. And these leadless pacemakers, as opposed to making an incision up by the shoulder, are generally inserted through a big blood vessel, most commonly from the femoral vein. That's the big blood vessel that comes back from the leg and connects to the lower abdomen. And so we'll put an IV in there and put a big catheter through that IV, as you might see in that picture, that comes up into the heart. And then we can place this device in just the right position of the heart, spend some time making sure we like where it is and that it's sensing and pacing well, and then disconnect our delivery system, take that out, and leaving just this little capsule behind. I also just want to spend a moment and just very briefly mention that there is another kind of pacemaker that I haven't touched on, and that's what's called a cardiac resynchronization device, or a CRT device. You might also hear it referred to as a biventricular pacemaker, or BIV. And that's a little bit different than what we've talked about so far. The biventricular pacemaker, or CRT device, is not necessarily meant to correct a slow heart rate, but is used for someone who has heart failure and the heart pump is a little weak, is not squeezing as well. Often these people have a level of dysynchrony, meaning that the walls of the heart are not beating together, but are beating in this sloshy kind of way. And by putting in this special kind of pacemaker that has an extra wire that goes over to this left side, enables the heart to kind of squeeze in a more synchronous, more unified way. And that improves the overall work output of the heart. And so that's a little exception to some of what we've been speaking about the indications someone might have for a pacemaker. But it's the same sort of idea in the sense that there's a can with the brains of the device and the battery up by the shoulder, and then the wires going through the blood vessels and into the heart.
Okay. So it sounds like if what a person has is sinus node dysfunction, kind of a garden variety, the heart's gotten older, the electrical, signal in the sinus node is either not coming as often as it should or having trouble spreading efficiently, then a pacemaker, especially if the person has been having symptoms, can be put in there, will sort of make sure the heart beats at least as often as it needs to. And that's the kind of, basic pacemaker, although now they have, I guess, these newer ones that don't have the wires. The wires are what you call the leads, right?
Exactly.
And so now we have leadless pacemakers. And then there's a fancier device that is really for people with heart failure, a cardiac resynchronization device is I think what you called it, or biventricular pacemaker. So you would use that more for heart failure. And then also I know sometimes when people get a device, there's also something that might shock them.
Yeah.
An implantable cardiac defibrillator, which people sometimes refer to as pacemakers, but those are not strictly speaking pacemakers. Can you just speak to what that is and how often are they combined with pacemakers?
Yeah, great point. So there's yet another family of what's called a cardiac implantable electrical device, and that's called an ICD, or implantable cardioverter defibrillator. And ICDs do everything that pacemakers do. So these ICDs are generally able to pace the heart, to keep the heart rate up if needed. But the indication for these devices and the extra feature of these devices makes them special. So sometimes when the heart is sick, it can beat not too slow, but really fast, in a really life-threatening fast way, an abnormal rhythm coming from the bottom chamber of the heart. So not the same as the atrial fibrillation that we have discussed here before, but this very fast, life-threatening rhythm that can cause someone to pass out or even die suddenly in what's called sudden cardiac death. And so what the defibrillator does is it watches. It watches the heart rate all the time. And if the heart rate gets really fast beyond a threshold that we're able to set, then it will assume that this person is having this life-threatening arrhythmia. And it will pace the heart even faster to try and break that circuit. But if that fails, it will deliver a high volt electrical activity and what we call a shock. And the idea is that shock is like hitting a reset button on the heart's electrical system and will restore normal rhythm. Now, I should mention that pacemakers, though they're giving these little electrical stimuli almost all the time, that's below the level of which we sense. So people generally don't feel the pacemaker doing its work. If the defibrillator fires, that is, if the person's still awake, can be felt as a kick in the chest, but is generally felt preferable to dying. The defibrillator is a little bit of a bigger device. So whereas a pacemaker might be about yay big, the space that I can kind of make by making a little circle with my fingers, a defibrillator is usually a little bit of a bigger footprint, a little bit of a fatter device, and a little bit heavier, because it has to have a much bigger battery to be able to generate that high level of electrical activity. But it's set up the same way as the traditional pacemaker. It's going to be a can up by the shoulder with wires going into the heart. And again, has the capability of pacing the heart too. So if someone needs both a pacemaker and a defibrillator, the defibrillator is all of that combined into one. But again, someone with heart failure or someone who's had a previous sudden cardiac death that they were resuscitated from, or who has had this ventricular tachycardia, could get that ICD without necessarily having had bradycardia as the reason.
Okay. And so it sounds like if a person is older and has had, again, sick sinus syndrome, we wouldn't normally be thinking of putting in an ICD for them. That's like way overkill. We just, a pacemaker that will keep an eye on things and keep goosing it along. And that is painless to live with and experience.
Correct.
Okay. But it sounds like people who've had more complicated heart conditions or who have had this kind of life-threatening fast heart rate, those are the ones who might get a device that can administer that shock if necessary to break a dangerously out of control heart.
Exactly.
Okay. Well, can you tell us now, what is it like to get a pacemaker put in?
Yeah. So, hopefully not a terrible experience. Often people come in and have the device put in and go home same day with a friend or a loved one to kind of watch over them from as they recover from the sedation that they had as part of the procedure. Sometimes, if they're coming and going on their own volition, or I shouldn't say volition, if they're coming and going on their own, they'll spend one night in the hospital with us. In terms of the procedure, the anesthesia or nurses will administer a certain level of sedation. So usually people don't really remember anything or experience pain during the procedure. The procedure itself takes about an hour or two. As I said, it's usually a small incision up by the shoulder or an IV to insert that leadless pacemaker. After the device implantation, depending which sort of device it is, there may be some movement restrictions. So, with a standard transvenous pacemaker up by the shoulder, we'll ask that for about 6 weeks afterward, you not raise the hand on the side of the device up above your head or lift anything heavier than about 10 to 15 pounds for that initial 6 weeks. And the purpose of that is to prevent that lead from getting pulled out of the position that it's been carefully put into. We don't want to have to do another procedure to replace that. After that initial 6 week period, pretty much almost anything goes. There generally aren't issues with household appliances. We do recommend not keeping your phone in a pocket, like on the same side of the device, just for a theoretical concern. But using cell phones, using microwaves, using electric blankets, all of that should be fine. Going back to swimming or golfing or biking or walking are all perfectly legitimate. The recovery from a leadless pacemaker insertion is a little bit faster. There aren't those same arm restrictions. We do recommend just to allow healing of that IV site, to not do any heavy lifting for about 5 to 7 days. And after that, you're back to full activity.
So, are leadless pacemakers becoming more popular? I'm just thinking 6 weeks without raising your arm over your shoulder. A lot of people can develop a certain restriction in their shoulder mobility
Yeah.
if they stop using the shoulder.
Yeah. So that reminds me to remind everyone that we definitely try and avoid this frozen shoulder phenomenon. So I do try and encourage people to use their arm. Like, you can still brush your teeth with that hand, or eat with that hand, or do things. What we're trying to avoid is a really big stretching motion. But you're right that can be a lot, especially for my older patients who might be using their both arms to kind of help pull themselves up, or using a walker and really leaning on that arm. And so I think the leadless pacemaker definitely is getting more popular because of and I think in particular among the more elderly patients, because of that faster healing time and the lack of some of those movement restrictions. The leadless pacemaker, you're sacrificing a few bells and whistles in terms of its ability to monitor what's happening in the heart intrinsically. It doesn't do quite as much of that. And it also doesn't have the ability to be upgraded to that biventricular pacemaker. If the person develops heart failure, you're kind of starting from scratch. And so there are some things that are lost, but I think for someone who just has a basic pacing need, I really think it's a great option.
Okay. And to come back to getting it put in, so the sedation, it's not, is it general anesthesia or is it just a little light kind of zoning you out and you kind
Correct.
of lie down on the
Yeah,
table?
more the latter. So again, of course it's going to be individualized to the individual person's needs, and so it'll depend a little bit on what other health problems a person has, and how able they are to lie still or cooperate, if they have anxiety issues, various things like that. But our default is to do to do this either under what's called conscious sedation or monitored anesthesia care, both of which are where you're still breathing on your own, but have a level of suppression of anxiety and a level of pain control and a level of just kind of helping you be more sleepy for the procedure.
Okay. And then does it hurt quite a lot in the space where the pacemaker was put in afterwards? Like how much pain control do people need
Yeah,
in the first few days?
that's a great question. So I would say, again, there's going to be a range of personal experience. Some people are, just much more feel things much more exquisitely, and also it depends if someone's more likely to have had a lot of bleeding for one reason or another, that can make it more painful. But I would say typically, most people tell me they take either no pain medication after the procedure is done, or they take a couple doses of Tylenol. And I would say that's the most common experience. It's pretty rare that somebody needs narcotics to manage pain after this procedure. So a certain level of discomfort that is resolved within a few days or a week, and usually that's about it.
Okay. And can you tell us a little bit more about what is it like to actually live with the pacemaker then? I mean, you were saying that afterwards you can be near household appliances. It's probably better not hold your phone there, but can you I would love for you to speak to, first of all, what kind of maintenance and care they need, in terms of like the battery or other monitoring, and how they get checked and adjusted, and then any restrictions like when people go through airports or other things that might come up for people who are living with a pacemaker.
Yeah, yeah, that's a great point, because the story's not over. Once you get the pacemaker, there is a level of care that needs to continue on forward to make sure that the device is doing what we hoped, and further to optimize it and to get all the information that it can be giving us to further your care. And so typically these days, a lot of that monitoring is done remotely. So either
Is there an app for this?
yeah. So either people are given a little device that you plug in the room where you sleep, and that can communicate just there remotely back to a center and come back to your healthcare provider.
Wait, is the device using Bluetooth or radio frequencies, or how is the device connecting with the pacemaker to get the information?
Yeah, so the device and the pacemaker often use radio frequency energy, or there's different ways depending
Mhm.
on the device.
Which is how we pay with our phones usually,
Yeah,
and with like the credit cards,
yeah,
right?
yeah. So,
Uh-huh.
and then they can be transtelephonic. So some of these use cellular technologies to communicate back. There's different modalities depending on the manufacturer and the specific device that a person has. And then sometimes an app on your cell phone can communicate and be used to send information. But one way or another, information can come from your device to your provider without you being in the same space as your provider. To be able to make changes to the device to tweak, we can change what the heart rate is. So maybe we set it to 60 beats a minute, but we find for someone who's a little sicker, they would prefer to have it at 70 beats a minute. Or maybe it's not doing quite as good a job kicking up the heart rate with exertion, and we want to tweak that. To make any changes like that requires an in-person visit to actually put changes to the device. So we can collect information from the device remotely, but to change the device, that's an in-person visit. And so,
And what do you
yeah.
do during the in-person visit to tell the pacemaker how to change what it's doing?
Yeah. So we'll use some sort of computer type device. And often there's an element that will go kind of near the patient's device. Although, again, with many of these devices that have radio frequency energy, it can be just a quick, like your phone, like a quick ding, and then you take it away. And then we're able to see what the device has kept track of. So the device will be able to tell us things like what kind of a histogram of what has your heart rate been over time. It can give us information if your heart's having any times that it's going really fast. Pacemakers don't treat fast heart rhythms. So unless you have one of those special devices, the the ICD or implantable defibrillator, the pacemaker won't necessarily break a tachycardia or fast heart rhythm, but it will observe and record it and let us know what's been happening. And so that can be really useful in figuring out what might be causing other symptoms. We can also track the battery, again, remotely or in person. And generally, these devices have about 7 to 10 years. Again, that depends a fair bit of battery life. And that follows a very clear reduction over time. And so we'll kind of keep tabs on that. And when you get to the point that there's getting close to the last 3 months is usually when we start thinking about changing that out. So that's another reason that it's important to continue a relationship with some healthcare provider that's helping monitor the device. We'll come back to that change out in a minute. I wanted to address a couple of the other points that you made. Usually after you get a device, you're given a little card, that identification card that says you have a pacemaker, here's the model, here's the serial number, and hang on to that card. And it is possible, if you are lucky enough to travel and go to an airport, that a pacemaker could set off a metal detector, depending how it's set or be noticed. And so usually you just tell them you have a pacemaker and may or may not show them the card, and they may or may not, wand that area. And that is perfectly fine and shouldn't disrupt the function of the pacemaker in any way. And hopefully shouldn't disrupt your travel plans too much either. I'll also just mention that these days, most pacemakers, if not all that are going in today and for the last several years, are able to have a person still get an MRI, or what we call MRI conditional. So these days, most of these devices don't stand in the way of any other care that you need. And again, the point of this is you get the device and it allows you to get back to and continue the life that you want. So we try and be pretty minimal in any restrictions or recommendations. Of course, there are these wires and there is the potential for them to break or have a problem. And so some things that put stress or tension on these wires are things like doing bench press or push-ups. So there are a few select exercises that I do recommend people try and avoid if possible. But these days, we even let people arc weld. So there's very, very few restrictions.
Yeah. Well, I myself have definitely had some patients who are even in their late 90s who were having some falls or dizzy spells, and we discovered that they had sinus node dysfunction. And once they got a pacemaker, it really turned things around for them, in an impressive way. But it might not be right for everybody who's of quite advanced age or frail to get a pacemaker. So can you speak a little bit about treating sinus node dysfunction and pacemakers in people who are particularly frail or maybe have Alzheimer's or another form of dementia, or who are, in their 90s or older? What's been your experience with that? And how do you think about it?
Yeah, that's a great question. So going back to our earlier discussion, we try and think carefully about how likely is this procedure, is putting someone through an implant procedure going to impact how they're feeling or their life expectancy or something. What are we getting for going through that? And that can be a trickier question in someone who's older to try and suss out. There's so many different things that can be going on. And sometimes people who have memory problems, it can be harder to tell, what are they experiencing and why they're experiencing it. And so, I'll try and be as transparent with the person in front of me and their family as I can to say, look, this may be helpful. It may not be. It's a little bit hard to tell. And then we'll together come up with a plan if it's consistent to try something, even if we're not 100% sure. The good thing about pacemakers is that the risk of the procedure is really quite low. We do a lot of these and the complication rate is pretty low. And so my threshold for thinking about it then similarly is pretty low. So even for somebody that, has some of these vague symptoms and their heart rate is in the 50s and I'm kind of not 100% sure, it's still something that we might consider because the chance of benefit is there and the risk side is not that high. So sometimes I've seen, as you mentioned, an older person get some benefit in their thinking, and that can be something that the patient and the family really appreciate, and is another endpoint that that we care about. And so I would say the way I think about it, pacemakers are really very much on the continuum of quality of life, of, you know, still within, even for people whose life expectancy might be on the order of just a few years, still might be something that we would consider just because of this improvement in quality of life, the low risk of doing it. And I think now having the option of the leadless pacemaker, where I don't have to worry if someone's memory isn't quite right, that they might scratch at it or move their arms in a certain way. We put the leadless in, and it's kind of more done, and the recovery is so fast. So I think that has even more opened up the possibility of thinking about this a little bit further.
Yeah. Well, it sounds like if somebody is experiencing bradycardia, slow heart rate that is giving them symptoms, this is something where when we put it in, they really can feel more energy, their mobility can be better, their ability to participate in life can be a lot better, and that it's normally a pretty simple, straightforward procedure. So even if somebody has Alzheimer's or memory problems or is quite up there in years, they could really benefit, especially if their heart rate has been low enough to be giving them significant symptoms.
Yeah, I'd agree with that. And I don't mean to oversell. I mean, there certainly are people who say, look, I don't really want any invasive procedures, and that's a reasonable approach for certain people at certain points in their life. But I do think that this is something that just because someone's in their 90s or just because they have a level of dementia, that doesn't necessarily take this off the table as far as I'm concerned.
Hmm. And it's also that it sounds like this isn't a particularly life extending procedure. This is just something that allows you to feel better and move around better in your life.
It depends. So again, if the indication for the device is AV block, then it is potentially life saving, and people can die suddenly from having no heart rate at all or completely insufficient heart rate. Sinus node dysfunction generally is not a life threatening condition. Generally, there can be extreme variants of that, but again, for the most part, for most elderly people, you're right. It's a quality of life thing. But sometimes people are what we call pacemaker dependent, where they, if their pacemaker weren't functioning, they would very likely die quickly.
Okay. So some people are pacemaker dependent in that way, but most people are not, is
Right.
what it sounds like.
Yeah.
Yeah. So that brings up something else I wanted to ask you about, which is, so what happens to pacemakers when it comes to the end of life? If somebody reaches that point where it looks like they might be in their last, months or maybe their last year of life, maybe they're considering being on hospice, what happens with the pacemaker? Can it be turned off? And what happens if it is turned off?
Yeah. So, yes, the pacemaker can be turned off, and your health provider should respect your wishes if that's the way that you decide to go. I would say that for pacemakers, it doesn't come up very often. And I think there's two reasons for that. One is that, again, for most people, they're not pacemaker dependent. So even if the device is turned off, it's not necessarily going to hasten death in a very quick manner. And I think the second reason for that is that, again, I think these devices are consistent with palliation and palliative therapy. These are things that help people feel better and improve quality of life. And so for many of my patients and people that I care for, it's not something that we're generally turning off at the end of life. But it is an option. And I will also contrast that with the other device that we spoke about earlier, the ICD or implantable cardioverter defibrillator. And that device is turned off a little bit more toward the end of life. Again, not 100%. Some people say, look, I want to keep living as long as possible, and that's fine too. But there definitely are people who say, I recognize that my end is near. dying quickly and suddenly of a cardiac arrest or a very fast, life-threatening arrhythmia, that's not such a bad way to go. And so would you please turn the shock therapy off of my defibrillator? And absolutely we can do that. And we can do that and still leave the pacing capabilities on if the person needs both of those things. And so it's entirely consistent and possible to continue having pacing function, but turn off the shocking function. And it is possible to turn off the pacemaker if that's what a patient and family decide they want.
Yeah. So to be clear, if people have a pacemaker, when they die, I mean, people aren't generally feeling the stimulus of the pacemaker, so it's not going to really make a difference to how they feel as they die. But if they have the device that actually shocks them, the bigger device, I mean, if it's not turned off, then when people are dying and their heart is starting to skitter to a stop or something, the device might shock them.
It might.
But it might not, because the heart might not be going super fast.
Correct. So it depends. Sometimes as we die, actually what happens is the heart goes into this pulsal electrical activity where it'll have some electrical activity, but it's not creating a squeeze function. And if the heart rate is not fast, the device, even the defibrillator still on, won't shock. So you can still die even with the defibrillator on, and you can still die even with the pacemaker on. It doesn't prevent that. The defibrillator with the shock function on is just preventing a death from very specific, fast, life-threatening arrhythmia.
Yeah, but as you were saying, that fast, life-threatening arrhythmia, is kind of your heart suddenly stopping, which is one way that people sometimes might think is not such a bad way to go.
Correct.
If we are in that end of life stage.
Correct. So right. So if the heart goes really fast like that, and that basically causes the pumping to kind of stop, and that's a very often felt to be a quick, painless way to go on that sudden cardiac death, and so people quite reasonably sometimes choose to have that device turned off.
Okay. Great. Well, this has been so helpful. Maybe we can just briefly recap what we talked about and then finish with some questions that people might ask their health provider or any other recommendations you have. So today we talked about bradycardia, which means slow heart rates, and how especially as people get older, it's very common for them to develop a slower than normal heart rate that might even give them symptoms because the electrical system in the heart, normally your heartbeat is generated by the sinoatrial node in the top, and that, as people age, gets maybe scarred or has deposits and doesn't create beats as often as possible, or maybe isn't able to step it up when we exert ourselves. And so that can be bradycardia. And we talked about how some common symptoms might be feeling weak or tired, especially when you exert yourself, or dizzy, or occasionally in some people, they might feel like they're about to pass out or even pass out. Or some older adults might even be a little bit more confused when their heart rate isn't fast enough. You were saying that to diagnose it, sometimes it's picked up incidentally. We notice a slow heart rate, but that otherwise we can do an EKG, look at the tracing of the heart, and then maybe gather more information over time by doing a stress test on a treadmill or having somebody wear a patch where we can see what their heart is doing over several days. And that's how we might confirm that they have this type of bradycardia. And then you said that to treat it and manage it, we look for reversible causes, medications. What else did you say were reversible causes? Thyroid.
And electrolytes.
And that this condition can also be caused potentially by other heart problems that people have had, can also affect the electrical system. And then that a pacemaker, if a person is often having a heartbeat that's too slow for their needs and giving them symptoms, a pacemaker can be very effective.
Yeah, excellent recap. Yeah, you covered a lot. There's a couple of things that I think might be of interest that I didn't get a chance to mention. And one is, I mentioned about that the battery on these devices lasts about 7 to 10 years, plus or minus, depending on how it's being used and exactly what kind of device you have. And so some people might be wondering, well, what happens then? And so at that point in time, we would do another procedure. And so if it's a standard pacemaker, the transvenous kind that's up here by the shoulder, we would again make a small incision. We would disconnect the device that's there from the wires that are sitting in the heart, and we would take that device out, and then we would put a brand new device in. So we can't actually at this time in 2025 replace the battery. We just actually replace the whole device, so it's a new battery and new device with the latest bells and whistles. If you have the leadless pacemaker that's sitting inside the heart, there's a couple options depending on the type of leadless pacemaker, potentially taking it out and putting a new one in versus just leave it in place and put a new one in beside it. In any of these cases, often when the device is replaced, if it's again up by the shoulder, usually that's a more simple procedure as we're just taking this out and not putting the wires in and out. So there's none of that arm movement restrictions, just instructions to kind of keep the wound clean and dry for a week or so. So I just wanted to make mention of that. One other thing I just wanted to mention is that depending on the indication for the device and what kind of heart rhythms the patient has had, we may put a device, it's again up by the shoulder here, that has one wire going into the heart or two wires going into the heart. Or if we're using that fancy resynchronization device, even three wires going into the heart. And so our listeners may hear things like a single chamber pacemaker or a dual chamber pacemaker kind of thrown around. And so I just wanted to make mention that a single chamber pacemaker just means that there's only one wire going into the heart, and that's all that's felt to be needed for this person. In general, we go with the simplest device that will meet all the needs. Less hardware we're putting in, the less things that could break or have a problem. And so just wanted to mention all of that. The very last thing that I feel I'd be neglectful if I didn't mention is that in our field, there's also some new thoughts about where to put the lead in the bottom chamber. So it used to be that if we were putting one of these leads or wires in the bottom chamber, the right ventricle, that we would put it in the apex of the bottom chamber, right at kind of the bottom point. These days, we're often putting it a little bit higher and kind of pointing into the septum or the wall between the two chambers of the heart. And you might hear terms like left bundle branch area pacing or conduction system pacing or something like that thrown around. And that just is this new technique of kind of where this lead is being put in the heart that's meant to be a little more physiologic and meant to preserve and keep the heart function normal over time.
Great. Okay. Well, that was wonderful. Thank you for those additional insights and tips about pacemakers. So in closing, if an older adult is, told to consider a pacemaker or is curious about a pacemaker, or maybe is told they have bradycardia, what are some questions that you would suggest that they ask their health providers?
Yeah, for sure. So I'd suggest that they talk to their healthcare providers if there might be any reversible etiologies. So make sure to run through all the medications that they're taking, including over-the-counter things, including things like eye drops, just to consider.
Let them know if you're taking any herbs or supplements.
Exactly.
You never know what's in those.
Yeah. So go over all of those things. Think about, what might there be options of things we can do, shy of a procedure to fix the problem. Secondly, I'd recommend that you talk to your provider and get a sense of, how confident are they that the symptoms that you're having are relating to bradycardia. Sometimes if it's not totally clear, doing some additional testing can create more peace of mind, for you and for your provider, and can be helpful or, take you in a different direction. And then finally, if it does look like there is, pathologic bradycardia and a pacemaker would be helpful to spend some time and talk about what sort of pacemaker, makes the most sense, because it's a little bit complicated and depends on how healthy the squeeze function of your heart is. So they may recommend doing an ultrasound or an echocardiogram to look at the squeeze function of the heart. to help determine and make sure that the type of pacemaker you're getting is the right one for you.
Okay. And any favorite resources to share for people who want to learn more about bradycardia or pacemakers?
Yeah, definitely. So, I think we'll post some things online. But I'd mention that both the American Heart Association and the Heart Rhythm Society have patient facing informational sites. The Heart Rhythm Society's site is called Upbeat, UPBEAT, and the AHA. I think you can just go to the AHA website and seek, patient information. And they both have some information about pacemakers. Also, many healthcare facilities, Cleveland Clinic, Mayo Clinic, and others have reliable information about these devices.
Okay, great. Well, Dr. Cara, this has been so informative. Thank you so much for taking us through bradycardia and pacemakers today. Thank you so much.
Absolutely. It's been my pleasure. Have a great day.
So thank you very much for watching. I hope you found this interesting and informative. If you found the video podcast helpful and you haven't yet subscribed, please do. It really does help more people find the channel, and it helps support the work that I'm doing at Better Health While Aging. If you've been listening to the audio version on the podcast feed, come and take a look at the video when you get a chance. You will see my key points being displayed on the screen. So thank you once again, and I look forward to seeing you all again on a future episode of the Better Health While Aging video podcast.